and I can hear that it's usually the death sleeping session now, isn't it, after lunch? But I can tell you we've got an amazing programme ahead, so we're really very much looking forward to it. I'm afraid we've lost our comedian, Robin Williamson, who unfortunately was only going to the morning. My name is Parveen Kumar, and I have the honour of being the president of the Royal Society of Medicine. So it's a great pleasure to welcome you all, and I think Robin already introduced you as to what we're here for, which is mainly education. But one of the highlights, I think, of the year is the Summit on Innovations, because we see such amazing, inspiring people, which really, certainly for me, kicks me up the backside and gets me doing things, which is terrific. Right, now, what we're going to do is... so I was just going to see whether we need to move in, but I think we're all right. There's room at the back. Our first speaker, and in fact all the speeches now are going to be, the talks are going to be very much in the interrelationship between patient, doctor, and, the patients and the doctor in medicine, and how we can actually get those together in a quicker way, really to the benefit of the health of the patients. And I think it's a very interesting program that Paul's put on together. Our first speaker is Neil Bacon, who I've known now for several years. Neil seems to be reinventing himself and coming up with something new. Now, he's a nephrologist, and he says it somehow isn't exciting enough to actually get him to finish his training, although I keep trying to tell him he must do so. But you'll probably remember him, or many of you will remember him, as having started Doctors Net, which really was the most wonderful chat. I think probably 80% of the doctors, junior doctors certainly, belong to it. He then came to me a few years ago when I was president of the BMA and had this crazy idea about iwantgreatcare.org. And it was again about patients now telling us what they thought of us doctors. So Neil, I'm delighted to see you're still thinking about something different. So do come back, but remember nephrology.
Thank you very much, Professor Kumar. Thank you, everybody, for your time. I'm conscious that this day is very crowded. You've given up your Saturday, so thank you already for giving me a time, and I look forward to your thoughts and opinions, very much so. You can't run a service which is about open, transparent feedback and not get open, transparent feedback yourself. Also like to apologise that I can't stay later on this afternoon. I'm supporting someone else later on, so hopefully I will speak quite quickly to compress it so as not to cut over the other speakers, but please, either afterwards or during, stand up and say stop. I want to ask you about that. There are no slides because it's the after lunch bit, so you have to stay awake. I appreciate it's that nice sleepy moment on a warm day. Background, as Professor Kumar said, I'm a nephrologist in training. I'll be the oldest trainee in the country if I go on like this, in the world probably. I am. I originally did my undergraduate training in Nottingham and then did most of my renal medicine in Oxford and Harvard. I exited out of Doctors Net UK, which is sort of last year's thing for me really, in 2008. Completely got out of that to launch I Want Great Care. Before I go into the sort of the rationale, the passion and how I Want Great Care works, I want to tell you a single clinical story. There's a chap who's a trainee surgeon. I think he's about 27, 28 now. He's been using I Want Great Care to get feedback from his patients. Every patient and every family is asked to rate and review him. He doesn't give the cards out. His receptionist or whoever's running the clinic does, to make sure there's no selection. He just thinks it's an important thing to do. He wants to know what his patients think. He wants to know when he fails them so he can improve. And he wants, obviously, to know when it goes well, because that reminds him why he does the job. 3 months ago, he had an elderly couple in front of him. The chap was 80 and had a Whipple's procedure. I'm sure the majority of you know, but for those that don't, Whipple's procedure is quite a ghastly, might not be the right word, but a huge operation, a really big undertaking in an attempt to, in this case, cure the man of his pancreatic cancer. The couple, his wife was 75, were in front of my colleague, and he had to tell them that, unfortunately, despite the huge operation, the pain and the discomfort that they'd been through, the cancer had returned and he would die in a few months. Obviously, it's never easy. It's always incredibly difficult. This time, he was just about to lean out and touch the arm of the patient, and the wife leant over to him and put her hand on his arm and said, thank you, doctor. You have been so kind with the way you told us this and taken us through this. And he was sort of a bit shocked. This was sort of slightly different. And then she said, but I knew you'd be kind, because when I knew my husband was going to be looked after by you, I looked you up on the internet. She didn't say, I looked up the cancer. She didn't say, I looked up Imperial, or which hospital. She says, I looked up you, because you were the person who was going to be operating on my darling husband. And we knew you'd be wonderful, because we saw what the other patients said about you. So for him, for my colleague, who's already obviously doing this, is quite advanced, he was shocked. Shocked that, firstly, and his own prejudice, someone 75, 80 was using the internet. So that's his you know what the young are like. They think no one else can do this stuff. Secondly, obviously a huge shock that they looked up him. And thirdly, that what they'd read had such an impact on the way they were relating to their care. So that's just, and we've got numerous stories like that. The way obviously, new ways of interacting transform relationships. And I believe what we're doing, combined with other things, has the potential to transform health and social care in a number of ways. Now, it's a huge, bold claim, and feel free to shoot it down. But I believe, and you've probably heard it from many people this morning, if you're going to have a dream and a vision, and you're going to create something new, build a company, employ people, you have to have a big vision and a big aim. I mean, that's the real thing I've learned. I meet people who say, oh, I've got an idea, I've got a dream. And often they're okay, they're a bit medium. If someone's really, really passionate about something, they're going to aim big. And we're aiming big with I Want Great Care, because I don't believe that healthcare is in any fit state to carry on as it is. I don't believe, especially in the UK, that medicine and healthcare has an awful lot to be proud of. Yes, parts of it are excellent, but the figures clearly show most is mediocre and a fair proportion is awful. We could all talk about examples all afternoon, but only got a few minutes. A couple of examples, though, just to flesh this out. Last year's National Audit Office report into diabetes care in the NHS. How many people do you think die from avoidable causes in this country every week related to diabetes? So these are avoidable deaths in the UK related to substandard diabetes care. There's 462 every week. So that's a jumbo jet crashing every week. That's how many people die unnecessarily in the NHS. That's just diabetes. If a plane crashed every week, that industry would be closed down. But that's happening now. That's happening now in the NHS. The CQC report just 3 days ago into health and social care. 25% of organisations didn't meet the standards. Again, would you fly on an airline that didn't meet the minimum standards? King's Fund study into general practice last year. Unacceptable variance and variation in the quality of general practice and its outcomes. So whichever way you look, there are massive problems and massive opportunities to improve. I think this is unacceptable. My belief before I set this business up was that traditional approaches, improving what we do now a little bit, wasn't going to change it. We really need a fundamental rethink and a reshape if we're going to make a difference to those sort of figures and get healthcare up to the quality standards expected from other sectors and other industries. So, why patient experience then? Why patient experience? Aren't these just stories that patients say? Can we trust them? Surely they're all going to be bad. Lots and lots of examples come to mind. Well, patient experience done properly predicts and correlates with clinical outcomes. Patient experience captured robustly and delivered back to staff improves staff morale and decreases staff turnover and sickness rate. Patient experience, high quality patient experience, what the patients say and think, is related to low cost of care, and it's also high quality experience is linked to low infection rates in hospitals. There's a huge bevy of evidence. So why are we ignoring it? There isn't a physician in this room who would accept not measuring, say, the haemoglobin if they're a haematologist, the creatinine clearance if they're a nephrologist. Yet every one of us in healthcare is critically involved in patient experience, but the vast majority of individuals and organisations do not measure it. That's now absolutely unacceptable. The definition of quality of healthcare by the WHO, Lord Darzi, Michael Porter in Harvard, is the quality of healthcare equals the clinical outcomes times the experience. So if you or your organisation are not measuring the experience and driving it upward, you are not measuring the quality of care. quite a profound thought, and it's not going away. So, how do we collect experience in a way that is meaningful and empowers and helps clinicians? And that's not just doctors, nurses, physios, pharmacists, OTs, everybody. How do we do it in a way that drives change, organisational change across the NHS and other sectors? And how do we do it in a way that meets the expectations and the demands of the public and patients? Any one of you right now can get out your phone, go to your computer and see the experience of people who stay in virtually every hotel in the world. Yet you can't find out the experience of the surgeon who's about to operate on your child. You can't find out the experience of other patients who you're about to go and be looked after by, maybe for your life. So there's this huge disconnect where we can get access to the experience of our peers, our friends, our colleagues about washing machines, bicycles, hotels, but the really, really important stuff, the stuff that's so important to individuals, and on a national basis, we have to get more efficiency, the financial targets, we can't access that information. There's not many doctors in this country who could put their hand on their heart and say, I know the experience my patients get. They might say, I think, or I perceive, but they don't know because they're not measuring it. So the aim of I Want Great Care is to make it incredibly simple for individual clinicians of all professions and organisations to collect huge volumes of continuous, real-time, quantitative and qualitative data, and then to embed that in the organisations to drive change and improvement, and for individuals, so they use it as a learning tool for self-reflection. We have doctors who are already now using it for their appraisal. Of course, for revalidation, it's going to be mandatory. But I believe that most doctors don't just want to meet the baseline. They don't just want to do the mandatory stuff. They want to do something bigger and better. And putting patient experience at the heart of what you do in an open, transparent way, and we might come back to that, transforms attitudes, even of the best clinicians. We've had teams where their morale, palliative care teams in Wales have been using this service for 4 years. Every patient and every relative receiving palliative care is asked to provide their feedback, either online or on paper forms, English, Welsh. And they do, huge numbers do. And the patients and their families say, thank you for giving us this opportunity to feedback. Thank you for giving us this opportunity to tell you what you did good and well, and to say thank you. And thank you for giving us the chance to point out where it needs to be better to help the next patient. So organisations use this service, as I mentioned, as a performance metric. Commissioning groups are embedding it in contracts. Providers are asking to have it embedded in contracts. Doctors using it as a tool, but most importantly, patients, back to my first story, patients and their families are now looking for information about the people, the organisations and the teams that are going to care for them. They're also expecting to be able to provide feedback, because they do in every other walk of life. And in every other sector, it's been shown to drive quality up. I believe if we don't we as the broader health, medical professions, don't provide a high quality, robust environment in which to corral and bring this together, patients will just write it everywhere. They'll write about you on Facebook and they'll write about you on Twitter, and you won't know what is being said. You will have no comeback. You will have no control of that tiny, tiny percentage of patients who are libeling, who are really fixated on one thing. Our aim is to provide us an environment, a context, a tool that is robust, safe, and meets the needs both of individual clinicians and, most importantly, their patients. So already for 4 years, we started the business 4 years ago, steady growth. It's interesting the PCTs disappearing had some impact. The government's drive for transparency, the information strategy, massive. Patient experience is at the heart of the changes. But interestingly, we're getting equal growth internationally. And we just this week actually signed up a company who operate health services in 34 countries in 18 languages. And we will be collecting real-time patient feedback across those. So I hope in this brief time, and apologies if I've gone too fast, but I hope I've given you a picture of why there is a massive need, how this could work, and the huge opportunities for both patients and those that care for them. Thank you very much for your time.
Thank you. It's lovely to see he hasn't lost his enthusiasm. It really carries me through every time. Nina, just before we get the questions, this was all about patients talking about their own doctors. But the doctor's not in isolation, because it's obviously he works in a system, and it's often the system that doesn't deliver. As you were saying, we've had these problems recently. You can't somehow get them to tell you about the system as well, because that might be a little bit more powerful to change it.
I think that's absolutely fundamental, and that's actually what we do, and we have done it from day one. People say, this is what I think about Professor Kumar, and then it says, thank you very much. Now could you tell us 30 seconds about the clinic where you were seen? And we know where the doctors work. Likewise, if someone provides their feedback on their general practitioner, it then says, now could you please tell us about the GP practice? 5 quick questions, a little slide bar and some text. It should be as easy to review your healthcare as it is to review your hotel. So absolutely, we have to have that differentiation. I'll ask you, perhaps people can have a think, I won't tell you, which they think get higher scores. Is it GPs or hospital specialists? And to your point, is it the doctor or is it the location and the nursing staff? Some interesting questions.
Who? Are you going to give us the answer?
It varies from specialty to specialty.
Yes, yes. Thank you. Could you give us your name? And I think we've got the, if you give it to the, all right, the lady in orange and then the gentleman at the back with the shirts. That's you.
It's an absolutely fabulous idea, and congratulations.
Louder, louder.
My one question would be, having my husband has just had a meeting with the Department of Health, the Restaurant Association and TripAdvisor this week, because they are all feeling and they know that TripAdvisor does not monitor the feedback carefully enough, and there are now several sites that one can pay to have favourable or non-favourable reviews sent to a restaurant or a hotel of your choice, and I just wondered how you thought you might address that in medicine.
Yep. So firstly, the TripAdvisor, sort of 10 years it's been going now, they've learnt an awful lot, and yes, the publicity about this review wasn't right always gets coverage. Cut a long story short, the founder of TripAdvisor and the CEO is an advisor to our board. In between running his $4 billion company, he runs our £4.50 company. He's a fantastic person, actually. He gives a lot of money. He's very involved in healthcare and medicine. But interestingly, we thought we'd learn from him, and we did, and we do. There are things we do to prevent rogue or unfair or inaccurate feedback campaigning that they've taken on and adapted to use on their site, because some of the things we've been doing are ahead of what they were doing. Interestingly, 98%, and it's a tiny number. I mean, it's important we get that tiny number and weed it out. Otherwise, it's got no credibility for the patient and no credibility for the doctor. The vast majority of attempts to game the system and to put false reviews come from doctors themselves. And we know who they are, we know where they are, and they think they're very clever, and it's sad. And they're not all just getting their receptionists or people to put lots of nice reviews about them. We've had people putting reviews of their colleagues, giving them negative reviews. The technology is very, very good, but it has to be. So I'm glad you brought that up.
Because this is one of the things I told you about earlier on, saying that, how can you actually stop that rogue person getting in? And
you can do, we do, and we have to, as otherwise, as my wife reminds me, our house would be on the line. So you have to make sure these things are robust.
Gentleman there. Name?
Hello, my name is Will Barker. I'm Will Barker at doctors.org.uk. So I'd like to first of all thank you, Neil, for my email address, and thank you, Parveen, for half my medical education.
I set it up just for you, Will. It's nice to meet you.
So I work in the NHS, and I do think that whilst it's definitely can go great lengths to improve quality, I think it's an amazing system. And let's not forget as well that maybe in America, there may be hundreds of people a week that die in the UK because of failure with the diabetes care. In America, there's probably thousands that die each week because of diabetes and lack of access to affordable healthcare. So my question is really, I do think this is probably broadly a good innovation. I think it definitely will transform medicine. I think it's a bit concerning about not knowing exactly where it's going to go. Certainly more information isn't necessarily always better, as sort of freedom of information is sometimes shown. And the risk with this sort of system is, sometimes it's the people that make the most noise aren't necessarily the people that need the most care. And is the risk that this could increase inequalities in health?
Thank you very much, Will. A number of key issues in there. Like you, I love the NHS. That's why I'm sort of still training in it, like you.
Do finish sometime, will you?
But the NHS is going to have to change and get better. Our aim is to highlight excellence. And much while some of the bottom end of the medical press would like to claim this is about naming and shaming, 96% of the reviews and the feedback on the site are overwhelmingly positive. But we have to highlight that excellence and drive out the stuff which isn't good, because that destroys morale and confidence in the NHS. It demoralises the staff who work really hard and do excellent. So we have to get much more robust and quantitative about it, because within every team there's people who just aren't up to scratch, and we need to be much more robust there because the NHS needs to improve and get better. As far as inequalities, I think again, this is one of the reasons we set this up. If we just left this to the market, there'd be that risk. One of the things we do, we work very hard with specific medical charities and different groups to raise the voice. The system is available in multiple languages. That's going to be really important. It's online and offline. We're not going to discriminate against people of any age as well. I'm going to say one more thing on that. For example, Breast Cancer Campaign, Terence Higgins Trust are just two of the organisations. They send messages out to their hundreds of thousands of members, say, give us the feedback on the care to raise up those issues. So I think it's a tool that has to be used by all sorts of sectors and all sorts of people.
Right, 2 quick questions and 2 quick answers. Bill Cattell.
Dr. Cattell, a very ancient nephrologist. I'm fascinated with your interest because this feedback from the patients is not new. Way back in the 70s, in the early days of dialysis, and particularly home dialysis, it was recognized very clearly that you had to have a really close relationship between your patients. And patients, in fact, commonly dictated what you wanted to do. I'm entirely on your side. There has to be feedback. What worries me, having been out of practice a long time, is that my younger colleagues, still in the NHS, appear to be totally demoralized. It's rather like education. Teachers are demoralized. And I think that before you're going to get any serious improvement, something has to be done about that.
Absolutely agree. And two quick points to that. Firstly, a study. The University of Wales did a study on the teams that have been using this system for 3 years. Morale goes up when you put this system in place, because absolutely the experience the patients get depends on the behaviour and actions of the staff, and that depends on their attitudes and staff. Secondly, as an N of 1, doctors, when they use this service, can sign up. They get an email every time they get a review. And one doctor said to me, it's the only email I like opening. He said, it's like getting a Christmas card every day, because 9 out of 10 of them are overwhelmingly really grateful patients expressing what a difference they made to their life. So this should improve morale.
It should do, because people are more inclined to complain than ever say how well you did, in general. Yes, please. And the last question.
Thank you very much.
Name?
My name's Joran Bergqvist. I'm one of the registrars at the Imperial College Healthcare Trust. I was just wondering sort of two things really. One is, I think you've said the point quite a few times of how you want to add figures and statistics and quantitative data to the website and to the service, because there's a slight there's often a disconnect between patient experience and results. And I would just have a slight concern that sometimes, even though you're getting maybe a great patient experience, actually results can be suboptimal. And quantitative data, I agree, will allow for transparency in that. But the question really I wanted to ask was how you're validating your service and how far along you are to the service being validated and being incorporated with existing feedback services like PALS, for example, and services that the NHS and trusts are currently using to look at this.
Firstly, I can absolutely reassure you, there are numerous studies now on both sides of the Atlantic showing that patient experience does link and correlate and predict clinical outcomes. So, of course, there's outliers, as with every treatment, everything. But if an organisation is delivering consistently high patient experience, it will deliver consistently high outcomes, and you can't get one without the other. So, Mid-Staffs is an example where actually you talk to them now, patient experience had gone off years before they detected it in clinical outcomes. Patient experience, we can share that. I'll share that. Send me an email. I'll send you the studies because they're great, and it's important that we get that message out. But it's also an early warning system as well, because it goes off before the mortality rate goes up. The second part of your question was the validation. Yeah, so the work's going on. I mean, it's interesting. PALS itself, is essentially a complaint system and has not been validated. Things like choices and others are there without validation. That's why, and I referred to the work done by the University of Wales. That's the first piece of work done. They've submitted 6 peer-reviewed papers, 3 of which have already been accepted, on validating this as well, linking it with face-to-face studies and others as well. So we can't do enough of that. We need to do more of that. This is a sort of an early science, but it needs to remain a science and not sort of wishy-washy stories.
Brilliant. Neil, thank you very much indeed.
Thank you.
Lovely to see you again.
Thank you.
Thank you. Well done.